You're listening to the recording on the management of patients with structural, infectious, and inflammatory cardiac disorders. The objectives for this lecture are for you to be able to describe the valvular disorders of the heart, including the pathophysiology, clinical manifestations, and medical and nursing management of patients with mitral aortic disorders, describe types of cardiac valve repair and replacement procedures used to treat valvular problems, as well as the care needed by the patients to undergo these procedures. Identify the pathophysiology, clinical manifestations, and medical and nursing management of patients with cardiomyopathies. Describe the pathophysiology, clinical manifestations, and medical and nursing management of patients with infections of the heart, and use the nursing process as a framework of care for a patient with a cardiomyopathy and a patient with pericarditis. Heart valves control the blood flow through the heart into the pulmonary artery and the aorta, as well as the atria and the ventricles. So this shows you the different type of valves up top. Here's your aortic valve, your tricuspid. If you notice, there's 3 flaps. That's why it's the tricuspid, and then the mitral is 2. Right there. Here is a cross-section of the heart. It shows you where the valves are and where the blood flow would go to and from. As far as valvular disorders, the 3 common disorders of the valves are regurgitation, which means the valve does not close properly, which allows backflow of blood through the valve. Stenosis is when the valve does not open completely, which reduces the blood flow, and a prolapse is a stretching of the AV valve leaflet into the atrium during diastole. So here's stenosis. Over on this side, regurgitation. So the difference between the stenosis and the regurg is neither one the flaps will function properly, but in stenosis there's actual scar tissue or fibrotic tissue that is causing the leaflets to become tough, and so they don't really open or close. With regurg, the valves are actually pretty loose. And then on the bottom, here's the prolapse. So you see here how the leaflet goes back up into the atrium. Most patients with mitral valve prolapse never have symptoms. A few do have symptoms. If they do, they'll complain of fatigue, shortness of breath, lightheadedness, dizziness, syncope. Some of them say that they can feel palpitations or chest pain, and then they just have generalized anxiety. The mitral valve leaflets will balloon back into the atrium during systole, and this allows regurgitation of blood from the left ventricle up into the atrium. The treatment is to control the symptoms, and sometimes the patient will need to get an antiarrhythmic in order to help control symptoms as well. Mitral regurgitation is when the blood flows back from the left ventricle into the left atrium during systole, making it difficult for the blood from the lungs to empty into the atrium. Most commonly, you'll see it in a patient who has rheumatic heart disease, as long as you're in a developed country. If you have underdeveloped countries, then you'll see it in different populations. Mitral stenosis is an obstruction of blood flowing from the left atrium into left ventricle, and this is commonly caused by rheumatic endocarditis. The blood cannot empty sufficiently into the ventricle, and this will cause a backflow into the pulmonary veins as well. This leads to an increased pulmonary arterial pressure as well as pulmonary congestion, which can cause more strain on the atrium. As far as diagnosis, your patient will have a weak, irregular pulse. They will have AFib, so if you do an ECG, you'll see AFib. Cardiac cath can be done with angiography, and treatment you want to try and prevent, so make sure they don't get the rheumatic endocarditis. minimize the risk for an infection. They can get anticoagulants. They can get cardioversion if they're having acute episodes of AFib that is not treated or reversed by medications. They can also be put on digoxin, but you'll need to watch for dig toxicity. They can be given beta blockers, calcium channel blockers, or have surgical procedures and interventions where they actually go in and replace the leaflets. We'll talk about that in a little bit. Aortic regurgitation occurs when the aortic valve does not completely close and the blood flows back to the left ventricle from the aorta during diastole. This, added to the blood being delivered by the left atrium, causes the ventricle to dilate and hypertrophy because you have blood that's going into the ventricle from two different places and it just can't hold that much volume. The arteries will try to compensate by reducing peripheral resistance and diastolic blood pressure. Signs and symptoms. At first, the patient does not have any signs and symptoms, but then they can develop arterial pulsations, and you can see and notice that at the temporal as well as the carotid arteries. The patient might complain of exertional dyspnea and fatigue, followed by symptoms of left ventricular failure. Aortic stenosis is caused by calcifications leading to narrowing of the orifice between the left ventricle and the aorta. To overcome the resistance, the left ventricle will contract more slowly, but with more power, increasing the pressure on that ventricle. The ventricle will eventually hypertrophy, causing heart failure. Aortic stenosis is a progressive disease. It will worsen over time. At first, the patient will be asymptomatic, but then they'll complain of orthopnea, exertional dyspnea. They can also complain of angina pectoris or pain with activity. They can also complain of fatigue. Education needs to include the disease process, the progression, and the treatment plan, as well as any new symptoms that need to be reported to the physician. The patient also needs to be educated on the increased chance for bacterial infection due to the diseased heart valve holding on to the pathogens. So the pathogens will take hold to those leaflets and they just don't let go. The patient can get infective endocarditis, so they really need to watch for being around anyone who has an infection. They need to do good hand hygiene practices. They should, in their home, have their own bathroom if it's possible. If not, they need to use their own soap, their own hand towels, not share washcloths. They shouldn't share utensils just in case someone has an infection and they're just not symptomatic. You want to look at trends in their heart rate, their blood pressure, respiratory rate. Listen to the heart and the lung sounds as well. See if you hear any murmurs, any gallops, any extra heartbeats. Assess for signs and symptoms of heart failure as well as dysrhythmia. So you'll want to do an ECG so that you can see what their electrical conduction is doing. They can get dysrhythmias from diseased valves. And the patient should be checking their weight at home. They should do it the same time every day. And they need to report any weight gain greater than 2 pounds in one day or 5 pounds in 1 week because it's most likely water weight and not just from overeating. As far as surgical management, repair of the valve is called a valvuloplasty. There are different types. The type of surgery that is performed depends on the cause as well as the type of dysfunction and the severity of the dysfunction. Most patients will be given general anesthesia, and they will be on a cardiopulmonary bypass machine during the procedure so that the heart can be worked on without any great potential of hemorrhage. This is what a balloon valvuloplasty looks like, and there are potential complications for this. That includes aortic regurgitation, an embolus, ventricular perforation, rupture of the aortic valve, ventricular dysrhythmia, mitral valve damage, and bleeding from the catheter insertion sites. What they do is they go into the heart and then they'll go down into that valve, and once the balloon is in the valve and it's forced open, they'll slowly open that balloon up, instill air into it, and that will force the valves to open and dilate. They can also do surgical repair around the valve itself. And if you look here, the annuloplasty ring insertion is repair of the valve annulus, and the annulus is just where the leaflets meet the heart wall. And what they do is they go in and they suture a ring around the leaflets, and the pressure of the blood flow along with the contraction of the muscle will force that valve to open because of the ring being there. They can actually resect the leaflet as well. And so when they do that, the leaflet resection is just removal of excess tissue from the leaflets, and then they can put the ring around it. As far as surgical management, most patients are given general anesthesia. They will be on cardiopulmonary bypass, so you'll need to monitor for complications of that post-op. Mechanical valves can be placed. They do not deteriorate or become infected as easily as tissue or cadaver valves. They're generally used in younger patients. As far as complications, thromboembolism and long-term use of anticoagulants can be potentials for complications. They will need to be on long-term anticoagulant or antiplatelet use. Bioprostheses are used for aortic, mitral, and tricuspid valve replacements. There is no need for long-term anticoagulants. It's generally used for patients who are over 70 years of age. Homografts are human valves that are obtained from cadaver tissue. These are very expensive. They also require donation as part of the organ donation that you guys either do or do not agree to whenever you get your driver's license. Autografts, this is an excision of the patient's own pulmonic valve, as well as a portion of the pulmonic artery for use as an aortic valve. They also do not need anticoagulation therapy if you do an autograft. As far as valve replacement, this is performed in a valvuloplasty is not an option due to fusion of the leaflets or fibrosis or calcification that causes complete immobilization of the valve leaflets. The old valve is trimmed away and the prosthetic valve is sutured in place. Once the valve is secured, the patient is taken off the cardiopulmonary bypass machine and flow is checked by Doppler TEE, and then once everything is working properly and the heart is functioning again, the surgery will be completed and the patient will be closed up. If you have a balloon valvuloplasty, monitor the puncture site. Assess heart sounds every 4 hours to make sure that there are no complications, and monitor for heart failure and emboli because that can be a common cause post-procedure. And then they need to lay flat. They need to have the pressure bandage, just like the cardiac cath. They will be on complete bed rest for a while. As far as surgical valvuloplasty or valve replacement, make sure your patients are hemodynamically stable. Make sure that they are awake, recovering from anesthesia, they have a patent airway, and they're sufficiently oxygenating the different tissues in the organs. Check their neurologic status, respiratory and cardiovascular systems, and then make sure they're perfusing well. As far as patient education, following mechanical valve replacement, antibiotic prophylaxis will be necessary anytime a patient has a dental procedure. So they need to let the dentist know that they have valve replacement so they can get that medication before they start the dental procedure. And they'll start the antibiotic and they'll get the procedure and finish up after the procedure is done. And that's to prevent endocarditis. Cardiomyopathy. It's a condition where you have a series of progressive events culminating in impaired cardiac output, and this can lead to heart failure, sudden death, as well as dysrhythmias. An echocardiogram is one of the most helpful diagnostic tools with hypertrophic cardiomyopathy because the structure and function of the ventricles can be observed pretty easily during the echo. Dilated cardiomyopathy occurs when there's significant dilation of the ventricles without simultaneous hypertrophy and systolic dysfunction. The ventricles have elevated systolic and diastolic volume, but they have a decreased ejection fraction. A typical ejection fraction is 55 to 65%. Hypertrophic cardiomyopathy is an autosomal dominant condition. And with this condition, the heart muscle will increase asymmetrically in size as well as in mass, especially along the septal area. With HCM, cardiac arrest may be the initial manifestation, especially in young people. So when you hear about patients having heart failure during a football game or football practice and they're in high school or they're just starting out in college, they most likely died because they had undiagnosed HCM. Restrictive cardiomyopathy occurs when diastolic dysfunction is caused by rigid ventricular walls. This impairs diastolic filling as well as ventricular stretching. Systolic function is normal with RCM, and this is usually associated with infiltrative type diseases. ARVC is when the myocardium is progressively infiltrated and replaced by fibrous scar tissue, as well as adipose tissue. It starts localized mainly in the right ventricle, but then it will progress to the rest of the heart, and that will cause heart failure. As far as an assessment for patients with cardiomyopathy, patients generally present with tachycardia, and you usually can hear either S3 or S4 in addition to your S1 and 2. Diastolic murmurs can be present with DCM, and systolic murmurs can be present with HCM. Diagnostics generally done by ruling out other causes of heart failure as well as doing an echo. A cardiac MRI can also be used, especially if they're looking for HCM. If you do an ECG, you might show dysrhythmias. Endomyocardial biopsy can also be performed, and that will show if there's any type of adipose or fibrotic type tissue. As far as interventions, do what you can to improve cardiac output and peripheral blood flow. The patient should rest. They should have their legs down. They might be put on supplemental oxygen, make sure they get their medications, they follow a restrictive diet, and they need to be well hydrated because if they're dehydrated, it increases the workload on the heart. You'll do periods of activity with periods of rest for the patient and slowly increase the activity to see if the patient can tolerate increased activity. And then watch their oxygen saturations as well to make sure that the perfusion is still sufficient and they're oxygenating their tissues. Talk to the patients about positive coping strategies, help them with their anxiety, and talk to the family as well because most of this is progressive. Some patients can feel powerless. There's nothing that they can do to stop it. It is a progressive disease. If they're younger, then they're going to be told that they can't do any type of strenuous activity, which means that they shouldn't be playing sports any longer. And if this is a younger person who is playing football, they want a scholarship to go to college, that's going to be a big blow to them. They need to focus, and you can help them with what they can control, what things they can still do, and ways that they can help themselves to slow the progression of the disease. Monitor their heart rate, their respiratory rate, listen to their heart and their lung sounds, monitor their weights. They should do daily weights when they're at home. Check their peripheral most pulses to make sure they're perfusing all the way out to their extremities. and have them do as much as possible without getting too tired. So even though it might take them a little bit longer, give them that time so that they can feel like they have some sort of sense of accomplishment. As far as infections of the heart, it can be in any of the 3 layers of the heart. As far as the infectious process, diseases are named by the layer of the heart that is affected, and diagnosis is done based on an echo as well as symptoms. The best treatment is actually prevention, or the best management is prevention, and them not getting the infection. Once you get an infection in the heart, it's really hard to treat. They generally need long-term antibiotics, and they'll need IV antibiotics at first, and then they'll be on oral antibiotics long-term. There are different types of infections. There's rheumatic endocarditis, infective endocarditis, myocarditis, and pericarditis, and we'll talk about all 4. Rheumatic endocarditis occurs most often in school-aged children, and it develops after a strep pharyngitis type infection. The strep generally is not treated as quickly as it needs to be, or the kids feel better, and because it's difficult for kids, for parents to get the kids to take the antibiotics, they don't have them take the full dose, and then the strep spreads. Patients will develop a heart murmur, cardiomegaly, pericarditis, as well as heart failure. So it's really important that whenever someone's diagnosed with strep or a kid has symptoms of strep, that they get tested and treated right away. Infective endocarditis is a microbial infection of the endothelial surface of the heart. It develops generally in those with the prosthetic heart valves, cardiac devices, or any kind of structural cardiac defect. It's also seen with IV drug users, patients who have chronic indwelling catheters, or prolonged IV therapy. Myocarditis is an inflammation of the myocardium. This causes dilation of the heart, thrombi, and infiltration of blood around the coronary vessels as well as between the muscle fibers. It can lead to cardiomyopathy as well as heart failure if it's not treated successfully. And then pericarditis is an inflammation of the pericardium. It can be primary or it can be secondary. So it can be caused by something else, or it just can come on by its own. It can be acute, chronic, or it can be recurring. It's not uncommon for patients who have pericarditis once to get it again. As far as clinical manifestations, no matter which form you have, most patients will present with the same types of symptoms. They'll have a heart murmur, they'll have a fever. If they have pericarditis, you'll hear the friction rub in the left sternal lower side of the sternum. If it's rheumatic, they can have the Roth spots. They can have the Osler nodes, and then they'll have the splinter hemorrhages in the nail beds. With myocarditis, generally they just complain of chest pain, pressure, fatigue, dyspnea, palpitations. The patient will have blood cultures drawn, both aerobic and anaerobic. They'll get an echo. They'll check the rheumatoid factor, and that'll tell if it's rheumatic or not. They'll do the SED rate, which is your ESR. They'll do the CRP, which is a C-reactive protein. They'll look at the urinalysis, see if they have any kind of urinary tract infection. They'll do an ECG to see if there's any electrical conduction, dysrhythmia type complications. They can get a cardiac cath, but again, if they have an active infection, then the catheterization can cause an increase in the spread of the pathogens. They can also get imaging, a CAT scan, and a TEE. Okay. Prevention is the best way to treat if a patient is going in for certain procedures, especially if they have some sort of valve replacement, then they need to be put on antibiotics prophylactically. They need to have good oral hygiene. You can have an infection or bacteria in the mouth or throat that will spread to the heart. Female patients are advised not to use IUDs because you can get infection from the IUD that becomes systemic and goes to the heart generally. If you have any patients who have IV catheters, urinary catheters, anything invasive that's long-term, then you need to make sure you do proper care and keep the sites clean. Make sure you do proper dressing changes if they have IV therapy, and that you're scrubbing the hub, doing everything that you can to prevent any kind of an infection. You want to remove any type of catheter as soon as they're no longer needed. And then the patients need to be up to date on their immunizations as well. If you want to listen to different types of heart sounds, you can go to this website. It has regular heart sounds, it has murmurs, gallops, and then it has the extra S3 and S4 in addition to the S1 and 2.